Hi, welcome to our channel of IGNOU audiobooks, Indira Gandhi National Open University, School of Health Sciences, SOHS, Diploma Programs, Diploma in Critical Care Nursing, DCCN, BNS 03 to Nursing Management in Critical Care Conditions, Block 1 Care of Critically Ill Patients with Problems of Gastrointestinal System, Unit 3 Hepatic Disorders Fulminant Hepatic Failure and Hepatic Encephalopathy. 3.0 Objectives. After completing this unit, you will be able to times enumerate the various causes of fulminant hepatic failure and hepatic encephalopathy, times identify the various signs and symptoms in a patient going into fulminant hepatic failure and hepatic encephalopathy. Times discuss the pathophysiological changes leading to various signs and symptoms in a patient with fulminant hepatic failure and hepatic encephalopathy. Times describe role of critical care nurse in the conservative management of a patient with fulminant hepatic failure and hepatic encephalopathy. Times explain the role of nurse in the various diagnostic tests for a patient planned for liver transplantation. Times describe the care of patient with liver transplantation, and times advise a patient to prevent the potential complications after autotrophic liver transplantation. 3.1 Introduction. Fulminant hepatic failure, FHF, and hepatic encephalopathy are one of the most catastrophic and challenging gastrointestinal emergencies encountered in clinical practice and encompasses a pattern of clinical symptoms and pathophysiological responses associated with the rapid arrest of normal hepatic function. FHF carried a very high mortality rate, widely reported to be in excess of 80%. However, with an improved understanding and recognition of the syndrome, more aggressive medical therapy, intensive care, and the advent of autotrophic liver transplantation, OLT, as a treatment option, survival rates have improved considerably. In this unit we shall discuss about definition, etiologic factors, pathophysiology, clinical manifestations, diagnostic assessment, therapeutic and nursing management of fulminant hepatic failure and hepatic encephalopathy. 3.2 Fulminant hepatic failure. We shall discuss various aspects of fulminant hepatic failure in following sub-sections. 3.2.1 Definition. Fulminant hepatic failure refers to the rapid development of severe acute liver injury with impaired function of synthesis and encephalopathy, often in association with coagulopathy, jaundice, and multisystem organ failure in a person who previously had a normal liver or had well-compensated liver disease. Several definitions of the time course for which liver failure should be considered. Fulminant have been proposed. Times the development of encephalopathy within 8 weeks of the onset of symptoms in a patient with a previously healthy liver. Times the appearance of encephalopathy within 2 weeks of developing jaundice, even in a patient with previous underlying liver dysfunction. Fulminant or acute hepatic failure is a sudden and severe impairment of liver or hepatic functions due to massive necrosis of liver cells. It is characterized by severe liver dysfunction, hepatic encephalopathy, metabolic derangements, neurological complications, and, ultimately, multi-organ failure in a patient without pre-existing liver disease. Patients who have rapid deterioration of liver function with the development of encephalopathy within 6 months but fall outside the boundaries of the above time intervals are considered to have subfulminant hepatic failure. Fulminant and subfulminant hepatic failure differs in their clinical features and prognosis. As an example, cerebral edema is common in fulminant disease and rare in subfulminant disease. In contrast, renal failure and portal hypertension are more frequently observed in patients with subfulminant hepatic failure. 3.2.2 Etiological factors. The etiological factors of fulminant hepatic failure may include following. Times viral hepatitis, hepatitis A and age, is the commonest cause, accounting for 60 to 75% of all cases. All viral infections causing acute hepatitis may be complicated by FHF. Other non-hepatotropic viruses, such as Epstein-Barr virus, cytomegalovirus, adenovirus, and herpes simplex virus can also cause FHF, but very rarely, vascular, right heart failure, Buddha-Chiari syndrome, veno-occlusive disease, shock liver, ischemic hepatitis, heat stroke, metabolic, acute fatty liver in pregnancy, Wilson's disease, Ray's syndrome, galactosemia, hereditary fructose intolerance, tyrosinemia, times miscellaneous, malignant infiltration, liver metastases, lymphoma, autoimmune hepatitis, sepsis, times toxins, carbon tetrachloride, phosphorus, industrial cleaning solvents, times hepatotoxic drug. Reactions example, anesthetic agents, nonsteroidal anti-inflammatory drugs, antidepressants, acetaminophen in TX doses with alcohol, idiosyncratic reaction halothane, sulfonamides, phenytoin, and others, times acute alcoholic hepatitis, times mushroom poisoning, times pregnancy complicated with eclampsia. 3.2.3 Pathophysiology. The pathogenesis of fulminant hepatic failure is uncertain, but it is thought that direct cytotoxic effects and a hyperimmune response to antigen, EU infection, with two or more viruses may be the initial events that, for still unknown reason, trigger rapid progress to liver failure instead of the usual recovery. Pathophysiologic alterations seen in FHF include cerebral edema, due to alteration in permeability of blood-brain barrier and passage of ammonia into the astrocytes, brain cells. Damaged liver lack in gluconeogenesis, which leads to elevated level of insulin followed by hypoglycemia. Liver damage alter the functions of synthesis and metabolism, which gives rise to symptoms of toxemia, coagulopathy, portal hypertension, ascites, altered bowel, and bladder function. The following flowchart will help to understand pathophysiological basic of FHF. Fig.3.1 Fig. 3.1 Flowchart showing pathophysiology of hepatic failure. 3.2.4 Clinical manifestations. The clinical manifestations are given in following table: subjective findings, headache, dizziness, nightmares, jaundice, vomiting. Objective findings: I. Altered mental status with agitation, uncooperative or violent behavior, delirium, mania, somnolence, and coma. A. Asterixis. B. Fata hepaticus. C. Small liver. D. Decerebrate rigidity and posturing in late stages. E. Abnormal pupil reflexes, usually dilated in late stages. F. Hypotension, tachycardia, arrhythmias. G. Tachypnea, respiratory arrest. H. Elevated temperature. I. Oliguria and uremia. J. Abnormal bleeding. K. Ascites. 3.2.5 Diagnostic assessment. The diagnostic evaluation includes following: I. Laboratory investigation of blood for bilirubin 20 mg%, transaminases usually high. 1000. IGNOU prolongation, decrease in C01 factors 5, 7, ammonia usually elevated, coagulopathy with prolonged PTT, arterial blood glass, ABG, analysis may reveal alkalosis or acidosis. BUN, creatinine increased, 2. CT scan of liver may present decreased size with areas of necrosis. 3. Percutaneous needle biopsy of the liver may reveal degree of hepatocellular necrosis. 4. Hepatic ultrasonography may demonstrate extrahepatic biliary obstruction and abnormal size of liver. Other assessment include ECG, EEG, chest X-ray. 3.2.6 Therapeutic management. The essentials of management aims at times diagnosis of cause of liver injury and encephalopathy, times. Skilled intensive care to minimize aggravating factors and complications until liver function recovers or transplantation can be performed. Conservative treatment, times parenteral hydration with attention to maintain normal electrolytes balance, times prevention or correction of hypoglycemia, times nutritional support with protein restriction aiming at the reduction of urea synthesis, times neomycin and lactulose aim to reduce the colonic production and absorption of ammonia, times prostacyclin, PGI2, a well-known vasodilator, may improve tissue hypoxia, times steroids, times coagulation abnormalities may be corrected with parenteral vitamin K. In cases of no response to vitamin K or suspicion of disseminated intravascular coagulopathy, fresh frozen plasma is indicated with or without platelet concentrate infusion. Plasma exchange has been suggested as another means that may correct homeostasis, times the reduction of gastric acidity by early use of H2 antagonists is important. To prevent stress-induced gastroduodenal disease and subsequent hemorrhage, times cerebral edema is a major complication of increased ICP and a common cause of death. Early detection is the key for effective treatment. Patients at risk of increased ICP should be placed in a head-up position with elevation of the trunk about 200 above the horizontal. However, higher elevation to 400 possibly produces paradoxical elevation of the ICP. Monitoring of the ICP by extradural transducers allows not only early detection of increased ICP but also guidance of therapy to prevent brainstem herniation. This has considerable implications for transplantation. Mannitol bolus reduces ICP, and more potently increases the overall survival rate. Times antibiotics are frequently administered to combat infection. Times artificial liver support devices are designed not only to remove circulating toxins but also to perform complex metabolic functions. In this, extracorporeal liver assist devices, ILAD, the blood of the patient is perfused through fiber cartridge containing living hepatocytes, times hepatic regeneration by growth factors stimulating hepatocyte proliferation, especially insulin and glucagon, are reported to be successful. Times mediator therapy, immunotherapies, selective bowel decontamination, and liver dialysis system are under trial. Liver transplantation. Despite all these medical measures, the mortality rate remains very high, varying from 50 to 85%. This has led to the introduction of autotropic liver transplantation, OLT, which reversed the prognosis with survival rates from 60 to 80%. Guidelines to select patients for autotropic liver transplantation, OLT. These criteria include A. Prothrombin time 100 seconds or any three of the following, times age 40 years, times non-A, non-B hepatitis, halothane or other drug-related etiology, times duration of jaundice before onset of encephalopathy to days, times prothrombin time 50 seconds. 5. Serum bilirubin 20 mg per dl, B. In paracetamol-induced FHF, times pH 7.3 or times prothrombin time 100 seconds and times creatinine 2 mg per dl. Times AIDS or RIV positivity, times irreversible brain damage, times multisystem failure that is not correctable by liver transplantation, times malignancy outside the liver, not skin cancer, times infection outside the hepatobiliary system, times active alcohol or substance abuse, times advanced cardiopulmonary or other systemic disease, factors that increase the risk of liver transplantation. These include times advanced age, times advanced chronic renal failure, times cholangiocarcinoma, times chronic hepatitis B virus infection, times hepatocellular carcinoma, times hypoxemia from intrapulmonary shunts. 3.2.7 Nursing management. Assessment. You have to do thorough assessment of all the body systems with special emphasis on metabolic dysfunction involving liver, pancreas, and biliary system by keeping in mind that you have gathered objective and subjective data. Refer 3.2.3 for prompt and accurate diagnosis and interventions. 2. Nursing diagnoses. Fulminant hepatic failure, times ineffective breathing pattern related to decreased lung expansion, times impaired gas exchange related to ventilation perfusion mismatching or intrapulmonary shunting, times decreased cardiac output related to alterations in preload, times decreased intracranial adaptive capacity related to failure of normal compensatory mechanisms, times ineffective renal tissue perfusion related to decreased renal blood flow, times disturbed body image related to actual change in body structure, function, or appearance, times deficient knowledge about discharge regimen related to lack of previous exposure to information, times potential for bleeding related to impaired synthesis of clotting factors. 3. Intervention. While you are taking care of patient with FHF, you have to keep in mind that your nursing priorities are directed towards the following points. I. Protecting the patient from injury. 2. Providing comfort and emotional support. 3. Maintaining surveillance for complex tilde teens, and 4. Educating the P tilde teens and family for effective home care. In order to fulfill the above mentioned priorities, you have to carry out following nursing interventions for providing care to the patients. Times assess LOC, times assess respiratory status and initiate measures to prevent complications. Times elevate head of the bed to at least 30 degrees, change position every 2 hours. Times assess signs of increased intracranial pressure and elevate the head by 30 degrees to normalize ICP and administer medications as advised like mannitol, steroids, etc. Times if there are signs of coagulopathy, you should prevent injury during nursing procedures. Times checking of vital signs, BP, pulse, respiration and temperature. Times blood sugar level need to be checked every 3 to 6 hours. Times maintain normal BP and CVP. Times administer fluid and electrolytes as advised. Times monitor urine output hourly. Times lactulose to produce 3 to 4 loose stools per day. Times administer medications as advised like cimetidine, vitamin K, preventive, antibiotics. Times give lactulose enemas to reduce ammonia level as advised. Times measure abdominal girth to assess the degree and abdominal distension ascites. Times use of benzodiazepines and other sedatives to be discouraged because of the masking of pertinent neurological changes. 3.3 Hepatic encephalopathy. Hepatic encephalopathy is considered to be a reversible metabolic encephalopathy which occurs as a complication of hepatocellular failure. Hepatic encephalopathy refers to the changes in the brain that occur in patients with advanced acute or chronic liver disease. If liver cells are damaged, certain substances that are normally cleansed from the blood by the healthy liver are not removed, ammonia mainly, and other toxins. Nurses working in ICD settings should be aware of the different precipitant to hepatic encephalopathy so that specific measures can be initiated to prevent the patient from going into encephalopathy and hence aiding in the early recovery of the patient. 3.3.1 Definition. Hepatic encephalopathy is a syndrome observed in patients with cirrhosis of the liver. It is a central nervous system dysfunction resulting from liver disease, frequently associated with elevated ammonia levels producing changes in mental status, altered level of consciousness, and coma. Hepatic encephalopathy may develop in patients without cirrhosis who have undergone portocaval shunt surgery. Classification. I. Categorization of hepatic encephalopathy. Hepatic encephalopathy can be divided into 3 categories. I. Encephalopathy associated with acute liver failure. 2. Encephalopathy associated with portosystemic bypass and no intrinsic hepatocellular disease. 3. Encephalopathy associated with cirrhosis and portal hypertension. 3.3.2 Etiological factors. 2. Proposed theories of hepatic encephalopathy are as follows. A. Ammonia hypothesis. Ammonia is produced in the gastrointestinal tract by bacterial degradation of amines, amino acids, purines, and urea. Normally, ammonia is detoxified in the liver by conversion to urea and glutamine by the Krebs-Henseleit cycle. In liver disease or in the presence of portosystemic shunting, the portal blood ammonia is not efficiently converted to urea. Increased levels of ammonia may enter the systemic circulation because of portosystemic shunting. B. Glutamine aminobutyric acid. GABA hypothesis. GABA is a neuroinhibitory substance produced in the gastrointestinal tract of all brain nerve endings. 24 to 45% may be GABAergic. Increased GABAergic tone is observed in patients with cirrhosis perhaps because of decreased hepatic metabolism of GABA. C. Other precipitating etiological factors are as follows. Times, metabolic disturbances may precipitate hepatic encephalopathy. Common among them are hyponatremia, often arising as a result of diuretic treatment or simply as a complication of the edema typically found in advanced cirrhosis, hypokalemia, again, often as a result of diuretic use, alkalosis, dehydration, hypoglycemia, a condition to which people with cirrhosis are susceptible. Times renal failure. Renal failure leads to decreased clearance of urea, ammonia, and other nitrogenous compounds. Times infection. Infection may predispose to impaired renal function and to increased tissue catabolism, both of which increase blood ammonia levels. Times constipation. Constipation increases intestinal production and absorption of ammonia. Times blood transfusions may result in mild hemolysis, with resulting elevated blood ammonia levels. Times diuretic therapy. Decreased serum potassium levels and alkalosis may facilitate the conversion of NH4 to NH3. Times there are several medications the use of which may lead to hepatic encephalopathy. These include benzodiazepine, e.g. diazepam, lorgepam, narcotics, and diuretics. Alcohol ingestion, whether or not it was the cause of the patient's liver disease, may also precipitate hepatic encephalopathy. Times in patient of non-compliance with dietary protein restriction. Times GI bleeding may also lead to hepatic encephalopathy. Blood contains large quantities of protein in the form of plasma proteins and hemoglobin. Hence, the presence of blood in the stomach or small intestine represents a protein load which, as a result of bacterial metabolism in the lumen of the gut, is converted to potentially toxic products such as ammonia. Times certain surgical procedures, for example, operations to relieve pressure in the portal vein by connecting it to the splenic vein or other systemic venous vessels, have the effect of diverting incoming intestinal venous blood away from the liver. This means that such ammonia-carrying blood will not be able to be purified by the liver. Encephalopathy can result. In a similar manner, the more recently developed TIPS, transjugular intrahepatic portosystemic shunt procedure, as you have learned in previous unit, often precipitates hepatic encephalopathy. 3.3.3 Pathophysiology. Due to the presence of scarring within the liver, cirrhosis leads to obstruction of the passage of blood through the liver, causing portal hypertension. Fig. 3.2. This means it is difficult for blood from the intestines to go through the liver to get back to the heart. Portal systemic anastomosis, shunts, develop, and portal blood from the intestinal veins will bypass the liver and return to the heart via another route without undergoing first-pass detoxification by the liver. Scarring, damaged, cirrhotic liver. Fig. 3.2. Flow chart of pathophysiology hepatic encephalopathy. Furthermore, in cirrhosis and other forms of liver disease, the damaged liver will not be functioning as well as it should be, so even blood that does travel through the liver may not be as detoxified as it otherwise would be. In fact, if the degree of liver damage and malfunction is severe, then, even in the absence of portal hypertension and the consequent bypassing of the liver by blood coming in from the intestines, hepatic encephalopathy will still occur. Such may well be the case, for example, following severe injury due to acetaminophen poisoning or acute viral infection. Example, hepatitis A. The toxic substances that accumulate in the setting of liver failure and affect the brain are still not well understood. They have been thought to include ammonia, NH3, and mercaptans. Ammonia is normally converted to urea by the liver and, as with mercaptans, is produced by the bacterial breakdown of protein in the intestines. Ammonia can cross the blood-brain barrier, where it causes the support cells of the brain, astrocytes, to swell. The swelling of the brain tissue increases intracranial pressure and can lead to coma or death via herniation of the brain stem. The flow chart, Fig. 3.2 will guide you to understand the pathophysiological basis of the disease. 3.3.4 Clinical manifestations. A. Changes of personality, consciousness, behavior and neuromuscular function, times reversal of sleep pattern hypersomnia, times apathy, times irritability, times personal neglect, times delirium, times coma, times impairment in spatial perception. B. Neurological signs, times hyperreflexia, times rigidity, times myoclonus, times asterixis, times decerebrate posturing. C. Stigmata of liver failure, times muscle wasting, times jaundice, times ascites, times pulmonary erythema, times edema, times spider telangiectasia, times fata hepaticus. Grading of symptoms. The symptoms can be divided into following 4 stages. Fig 3.3. Stage 1 times euphoria or depression, mild confusion, slurred speech, irritability, decreased attention, disordered sleep rhythm, slight asterixis, and normal EEG. Stage 2 times lethargy, moderate confusion, marked asterixis, and abnormal EEG, personality changes. Intermittent disorientation, suppressed level of consciousness but responsive to painful stimuli. Stage 3 times marked confusion, incoherent speech, sleeping but arousable, gross disorientation, asterixis present, and abnormal EEG. Stage 4 times coma, initially responsive to noxious stimuli, later unresponsive, asterixis absent, and abnormal EEG, decerebrate posturing. 3.3.5 Diagnostic assessment, times history and physical examination, times blood examination for the following: ammonia increase, serum level, liver enzymes increase, ABG analysis, metabolic acidosis, serum albumin decrease with progressive liver disease, times EEG shows increasing amplitude with decreasing frequency, and the development of triphasic waves in late stage of coma, times MRI of brain to exclude intracranial lesion, times CF scan of liver as well as brain, times needle biopsy of liver to demonstrate level of necrosis, times hepatic USG will rule out extrahepatic obstruction if any. 3.3.6 Therapeutic management. The goal of management would be focused on mainly 2 times reduce the protein breakdown, times reduce the level of scent, rum ammonia as rapid as possible, times restore the normal functioning of other systems, times minimize the complications, conservative medical treatment. To achieve the above-mentioned goals, following interventions need to be carried out, times IV administration of glucose to minimize protein breakdown, times administration of vitamins and electrolytes to C0 ITEC deficiencies, times initial lactulose dosing is 30 ml orally, daily or twice daily. The dose may be increased as tolerated. Patients should be instructed to reduce lactulose dosing in the event of diarrhea, abdominal cramping, or bloating. Patients should take sufficient lactulose as to have 2 to 4 loose stools per day. Higher doses of lactulose may be administered orally or by nasogastric tube to patients with severe hepatic encephalopathy. Lactulose may be administered as an enema to comatose patients every 4 hours as needed, who are unable to take the medication by mouth. Lactulose, beta-galactosidofructose, is a non-absorbable disaccharide. It may inhibit intestinal ammonia production by a number of mechanisms. Lactulose is degraded by colonic bacteria and converted to lactic acid and other acids, with resulting acidification of the gut lumen. This favors conversion of NH4 to NH3 and the passage of NH3 from tissues into the lumen. Gut acidification inhibits ammoniagenic coliform bacteria, leading to increased levels of non-ammoniagenic lactobacilli. Lactulose works as a cathartic, reducing colonic bacterial load. Times antibiotics, such as metronidazole, oral vancomycin, paromomycin, and oral quinolones, are administered in an effort to decrease the colonic concentration of ammoniagenic bacteria. Times ornithine aspartate lowers serum ammonia levels through stimulation of the urea cycle and urea formation. times sodium benzoate reacts with glycine to form hippurate, increases ammonia excretion in urine, times osmotic diuretics to reduce cerebral edema, times serum ammonia levels are measured daily. 3.3.7 Nursing management. Assessment. As you know, a prompt and accurate nursing assessment is a pillar of effective management. So the following box will help you identify the severity of disease by analyzing the key clinical features of HE. Box 3.2. Staging of hepatic encephalopathy along with signs and symptoms to be assessed. Stage 1 times euphoria or depression, mild confusion, slurred speech, irritability, decreased attention, disordered sleep rhythm. Slight, asterixis and normal EEG. Stage 2 times lethargy, moderate confusion, marked asterixis and abnormal EEG, personality changes. Intermittent disorientation, suppressed, level of consciousness but responsive to painful stimuli. Stage 3 times marked confusion, incoherent speech, sleeping but arousable, gross disorientation, asterixis present and abnormal EEG. Stage 4 times coma, initially responsive to noxious stimuli, later unresponsive, asterixis absent and abnormal EEG, decerebrate posturing. Along with this, you need to assess following parameters. A daily record of handwriting and performance in arithmetic is kept too. Monitor mental status, checking of vital signs, i.e., blood pressure, pulse, respiration and temperature. 2. Nursing diagnosis, times altered level of sensorium related to cerebral edema secondary to NH3, accumulation and disease process. Times activity intolerance related to disease process, times deficient fluid volume related to bleeding, decreased intake, times altered nutrition less than body requirement related to disease process, times ineffective breathing pattern related to ascites, times potential for altered tissue perfusion related to disease process, times potential for infection. 3. Intervention. You need to carry out following activities to provide nursing care to critically ill patients with hepatoencephalopathy, times monitor levels of consciousness, mood and cognitive functioning and orientation, times maintain patent airway to prevent hypoxia, times maintain fluid and electrolyte balance, times meet the nutritional requirement, less protein and high carbohydrate diet is given, times maintain fluid intake and output record. Body weight is recorded daily, times note the frequency and quality of stools, times watch the signs of internal bleeding, times encourage bowel cleansing, times protect the patient from self-injury, times watch the signs of infection, maintain aseptic technique while attending the patient, care of urinary catheter, personal hygiene, and care of tubing, etc. Times protect renal functions by restricting sodium intake. Monitoring and maintain fluid intake, times follow-up advice, times give advice related to the following aspects of care: medications as advised, diet as advised, use of vegetable rather than animal proteins, preventing infection, avoiding over-the-counter medications, frequent liver enzyme studies. 3.4 Complications. You may find the following complications when your patient is suffering from HE, times ascites, times jaundice, times hepatorenal syndrome. 3.5 Summary. Fulminant hepatic failure is a complex clinical syndrome that has a diverse etiology, an unpredictable course, and a high mortality rate. The acutely ill patients admitted to the ICU with this condition often presents a challenge to the intensive care staff because of the life-threatening, multisystem complications. Hepatic encephalopathy is a common complication of liver cirrhosis occurring in up to 80% of patients and is characterized by neuropsychiatric complications ranging from slight altered mental status to coma, while the underlying mechanisms remain poorly understood with several proposed hypothesized theories. The mainstay of treatments is aimed at identifying and treating the precipitating causes or reducing intestinal ammonia production. In this unit, we have focused on definition, etiology, pathophysiology, clinical manifestations, diagnostic assessment, therapeutic management, and nursing management. The Various flowcharts have been presented throughout the unit to clarify the content. Thank you. Subscribe to our channel for more updates, and we will see you with the next chapter.